We are very pleased to welcome you to the Omnicurus Originals Gynecology series. Today we have Dr. Rekha Upadhyaya with us. Dr. Rekha is the present secretary of Manipal chapter, KSOGA. She is an associate professor in Department of Obstetrics and Gynecology at KMC Manipal. She is trained in oncology at Tata Memorial, Mumbai. She has been the treasurer in Manipal Obstetrics and Gynecology Society from 2015 to 2017 and secretary from 2017 to December 2020. She has delivered multiple presentations at various national and international conferences. She received Best Poster Award at 2018 AICOG and is a reviewer of Index Specialty Journals. Welcome Dr. Rekha Upadhyaya. The stage is all yours. You may please begin.
Thank you very much. Thank you Omnicurus for giving me the opportunity. Bringing you greetings from Kasturba Medical College, Kasturba Hospital, where I am currently working. Today's topic, I would like to take this opportunity to discuss on role of progesterone. Progestrogens are widely used in gynecology, especially progesterone role in the endometrial hyperplasia, which is a precursor of endometrial carcinoma, is a subject of interest. Today I will be discussing about different classification which have been evolved over years regarding the treatment of endometrial hyperplasia, risk factors associated with endometrial hyperplasia, treatment guidelines, what are the types of progestins are currently used and its evidence, some points about non-progestogens and role of surgery in the failure of treatment with progestins, and role of progestin in advanced stage and the recurrent endometrial cancers. Endometrial hyperplasia is a spectrum of changes that happens in the endometrium, which is slightly exaggerated in the late proliferative phase of menstrual cycle, and it varies from proliferative changes to irregular hyperchromatic lesions that are almost similar to endometrial adenocarcinoma. Endometrial hyperplasia is a precursor of ultimate spectrum disorder. In India, incidence of age-specific ratio is 2.3 per 1 lakh as compared to world where it is 8.4 per 1 lakh. This has been attributed to changing trends in the lifestyle and reproductive profile of women. The major concern regarding endometrial carcinoma is 5-year survival rates have not improved over past 3 decades. 80% of endometrioid type of histology which is seen in endometrial hyperplasia is supposed to be seen in type 1 endometrial carcinoma, which represents the continuum of loss of histopathological differentiation and disorderly overgrowth of endometrial glands. That is why early detection, prevention and treatment of endometrial hyperplasia is the key prevention of endometrial carcinoma. The role of progestin definitely there is a role of progestins in the prevention of endometrial hyperplasia, treatment of endometrial hyperplasia, treatment of endometrial carcinoma and recurrence of endometrial carcinoma. So we shall be discussing about different types of progestins and its role in each. This diagram gives a picture of proliferative and secretory endometrium, then how it becomes abnormal with atypia, without atypia, hyperplasia or hyperplasia with atypia. And this is just a schematic diagram. Individually, I'll be discussing further. When a patient comes to gynecological OPD with the abnormal uterine bleeding in a premenopausal or perimenopausal or patient with postmenopausal bleeding, we usually subject the patient for, after taking detailed history, high risk category, ruling out high risk category, family background, and we subject the patient for vaginal ultrasound, wherein endometrial hyperplasia, if it is detected, patient will be subjected to endometrial biopsy or OPD basis. We can do a Pipelle endometrial sampling or office cystoscopy may be done based on the histopathological finding, whether it is simple hyperplasia, complex hyperplasia or atypical variety. The treatment plan will be discussed with the patient. So in each of this category, you can see here low dose of progestin, high dose of progestin, used in the simple hyperplasia in a premenopausal patients, and some patients with postmenopausal also has been used. Only in cases of atypical hyperplasia there is a role of non-responsive to high dose progesterone, then you will go for a hysterectomy. Otherwise, there is a wide range of usage of progestin in the simple hyperplasia, complex hyperplasia, as well as in a premenopausal patient with atypical hyperplasia. Histoscopic picture gives a chance to identify the type of endometrium. In atrophic endometrium commonly seen in the postmenopausal women, it looks like a starry sky appearance. In a secretory endometrium, looks like a strawberry appearance, and there are sometimes you get to see a small polyp protruding into the endometrial canal, and there can be histoscopic finding. If you find a polypoidal abnormal endometrial hyperplasia, we do suspect either hyperplasia with or without atypia, and in full-blown endometrial cancer, there can be a bizarre appearance. Usually, when a histopathology report comes without atypia or with atypia, we usually plan accordingly, especially endometrial hyperplasia without atypia. Take into consideration, address all the risk factors, then treatment options of progestin in the form of long-term LNG, IUS or Mirena or oral progestins are concerned. Same time, a patients of fertility requiring not willing for surgery or surgery is contraindicated. In such patient also similar step is followed. In a patient with atypical hyperplasia, on the first go, hysterectomy is preferred. The later onwards, when the patient comes back with the review of treatment, if there is a regression or depending on whether there is a persistence or progression, the further management is decided. In the persistence of disease or progression, obviously there is not much of a chance for medical management. They usually have to subject for hysterectomy or curative treatment. If there is a chance of regression at the review of treatment, whatever first line treatment we have started with either Mirena or oral progestin, then we can follow based on the high risk category. The endometrial hyperplasia category or atypical hyperplasia category will be followed up with annual or with the endometrial biopsy follow-up. So the choice of endometrial hyperplasia management usually depends on the age of the patient, premenopausal or postmenopausal status, presence of cytological atypia, desire for future fertility, and the surgical risk. That is because endometrial hyperplasia without atypia has 1 to 5% chances of progressing to cancer, but endometrial hyperplasia with atypia, there is a definitive increase up to 27%. The possibility of concomitant cancer like ovarian or breast cancer definitely increases the incidence of endometrial hyperplasia progressing into cancer up to 43%. The progesterone has a role in prevention, treatment and of endometrial hyperplasia and treatment of endometrial carcinoma by remodeling the endometrium, and it acts both on epithelial and stromal compartments. The progesterone action is through modulation of progesterone receptors. There are two isoforms of progesterone receptor A and B has been identified. Progesterone A modulates the anti-proliferative effect of progesterone. Progesterone B receptor induces cell growth in the absence of progesterone receptor A. Both of these are transcribed from same gene by two distinct promoters. The difference is progesterone receptor A has lacking 164 at amino acid at amino terminus as compared to progesterone B receptor. Prior to ovulation, there is an equal amount of progesterone A and B receptors, but it eventually decreases in the secretory phase. In the stroma, progesterone expression is constant and more predominantly it is progesterone receptor A. In the nuclear content, there is progesterone B, which has a significant association with tumor differentiation. What is the background pathology in endometrial hyperplasia? There's an irregular proliferation of endometrial glands with an increase in the gland to stromal ratio when compared to proliferative endometrium. As I earlier told, it is an exaggeration of late proliferative stage which mimics endometrioid adenocarcinoma. When does this endometrial hyperplasia develop? When there is an unopposed estrogen by progesterone and stimulation of cell growth by binding to estrogen receptors in the nuclei of endometrial cells. Patient of endometrial hyperplasia may present with abnormal uterine bleeding, heavy menstrual flow, intermenstrual bleeding, unscheduled bleeding on hormonal replacement therapy, or they may present as postmenopausal bleeding. There are several risk factors identified. It is same for endometrial hyperplasia and endometrial carcinoma. Early menarche and late menopause, chronic anovulation, nulliparity, and pre-existing diseases like obesity, overweight, high body mass index more than 35, diabetes mellitus associated with these, infertility, hypertension, polycystic ovarian syndrome, hormone secreting tumors, and hereditary non-polyposis colonic cancer such as Lynch syndrome. Patients who are on hormonal therapy, especially tamoxifen in a breast cancer or estrogen replacement therapy patient in the presence of uterus, are at high risk for endometrial hyperplasia. Genetic factor is known to be associated with atypical type of endometrial hyperplasia, and there are several inflammatory markers and cytokines are identified with the abnormal endometrial hyperplasia such as tumor necrosis factors, EGF and IGF factors. Since the 1961 till date, there had been several time modification of classification of endometrial hyperplasia. The one which you have been following is 1994 WHO classification, which has been revised in 2014, and endometrial intraepithelial neoplasia classification. According to 1994 WHO classification, which we all know we have studied in undergraduate level, wherein simple hyperplasia without atypia, progression rate to cancer is 1%, where number of glands are increased, but the regular architecture is not compromised. In the second category, simple hyperplasia with atypia, wherein progression rate to cancer is 8%, wherein there is a features of nuclear atypia, that is marked variation in nuclear shape and size and prominent nuclear seen. In the complex hyperplasia without atypia variety, that it progresses to cancer up to 3%, wherein glands become more crowded and irregular. The complex hyperplasia with atypia, which has a high progression rate up to 29%, which has definitive complexity of architecture with atypical features. What has been modified in the revised 2014 WHO classification is they have categorized the abnormal endometrial hyperplasia based on the presence or absence of cytological atypia into two categories. That is hyperplasia without atypia and atypical hyperplasia. The complexity of architecture, which was there in 1994 classification, is no longer part of classification. That is based on the finding like hyperplasia without atypia involves no significant genetic changes, but in atypical endometrial hyperplasia, there is a strong association of genetic factors as well as microsatellite instability, backs to inactivation, KRAS and B-catenin also. In the EIN classification for the practical purpose, based on the topography and functional category, it is categorized into benign endometrial hyperplasia, endometrial intraepithelial neoplasia, and endometrial adenocarcinoma, endometrioid type, well differentiated. So this is either estrogen excess, precancerous lesion, and malignant. There are several progestins have been used in the early endometrial cancer, including endometrial hyperplasia without atypia and with atypia, and later in the type 1 grade 1 endometrial carcinoma and recurrence of endometrial carcinoma. The progestins which are in the practice are medroxyprogesterone acetate, all are synthetic progesterone, megestrol acetate, levonorgestrel, norethistron acetate, megestrol acetate in combination with metformin, and LNG-IUS or Mirena with metformin. So all these are the steroid progestin which are used either oral or intramuscular or implant. Other than that, there are certain non-progestin also there has been in the practice, but we will be discussing only about the progesterone therapies. The progestins which are commonly used in treatment of endometrial hyperplasia are the conventional progesterone, medroxyprogesterone is the one, megestrol acetate, and levonorgestrel IUD. The medroxyprogesterone and megestrol acetate, these can be used as a cyclical preparation, that is 2 weeks in each month, that is second half of the cycle, or it can be used continuously. We shall be discussing what is the advantage of continuous over cyclical or what is the disadvantage of cyclical therapy of progesterone later. Medroxyprogesterone, it can be used as oral preparation or injectable preparation, 10 milligram per orally as a cyclical or continuous for 3 months, or if there is a partial response, we can continue this into multiple doses 4 times daily, almost another 3 months. Or in the similarly, Depo-Provera injection also can be used. Megestrol acetate in the form of Mekes, the dose varies from 80 milligram to maximum up to 320 milligram. This also can be used as a cyclical or continuous preparation. Levonorgestrel IUD in the form of Mirena, it is an implant which 20 microgram per day release will be there. Minimum use advised for endometrial hyperplasia regression is from 6 months to 2 years. But advantage in LNG IUS is it can be kept for 5 years also because of its additional advantages. If you find an endometrial hyperplasia and if you find a small polyp, the recommendation is complete removal of uterine polyp and definitely take an endometrial biopsy to look for a background endometrium, even if it looks healthy on histoscopy, and then the management according to histopathological classification of endometrial hyperplasia. The endometrial polyps are the discrete overgrowth of endometrium, and ATPI is restricted usually to the foci within the polyp. In the absence of background hyperplasia of endometrium, if only polyp is having hyperplastic changes or atypia, removal of polyp may be curative. But if there is an atypical hyperplasia change in the polyp, there is also chance of associated hyperplasia of the surrounding endometrium. That is the reason why just removal of polyp is not sufficient. You need to take a sample of the background endometrium also. The first line of medical management in hyperplasia without atypia is LNG IUS, intrauterine device, Mirena, because of its lesser side effects, higher regression rate, more favorable bleeding profile, increasing efficacy, and also continuous contraceptive benefit if it is continued beyond the regression time. The oral progesterones are recommended in patients who decline to go for a LNG IUS. Later, I'll be discussing some of the studies wherein why LNG IUS is taken as a first choice of treatment compared to continuous or cyclical progestins. So in a patient, when we counsel for LNG IUS, if they are not willing, then continuous progestins may be recommended. Medroxyprogesterone acetate of 10 to 20 milligram per day or norethisterone 10 to 15 milligram per day from 3 months to 6 months. Again, decision on continuing up to 3 months or 6 months again depends on the regression level. Cyclical progesterone ideally not recommended because studies suggest that they have a less efficacy in inducing regression of endometrial hyperplasia without atypia when compared to continuous oral progestins and LNG IUS. How does progesterone act? They activate dehydroxylase enzyme to convert the highly potent estradiol into less active estrone. The well-known other mechanism is activation of progesterone receptors resulting in stromal decidualization and thinning of endometrium. They decrease the estrogen and progesterone receptor. This looks like a contradictory statement because when the progesterones are used for long time high dose progestin, they deplete the progesterone receptors. So that is why initially there will be a very rapid regression, but after a long time, sometimes there can be uncommon progression to severe disease may be there. So that is why the molecular biology or the mechanism of receptor action is very important in understanding and continuing the treatment. Progestins decreases the glandular cellularity by inducing apoptosis and to inhibit the angiogenesis in the myometrium immediately underlying the complex endometrial hyperplasia. The treatment duration and follow-up of progesterone based on several studies that treatment should be at least for 6 months in contrast to 3 months. Endometrial surveillance should be done 6-month intervals. When 2 consecutive 6-monthly negative biopsies should be obtained, then you can subject the patient for annual endometrial biopsy. Further referral if there is an abnormal vaginal bleeding recurs even after the completion of treatment, as this may indicate disease relapse. The relapse rate in oral progestins is 30% and LNG-IUS it is 14%. The surveillance of patients on OPD basis is based on outpatient endometrial biopsy, which is recommended after diagnosis of hyperplasia without atypia. But there is certain concern in the patients with high risk of relapse are the women of BMI more than 35 or greater, or patients who are treated on oral progestin 3 to 6 months, wherein 6 monthly endometrial biopsy is recommended. Patients who are on LNG-IUS also, you have to take a endometrial sampling, wherein outpatient based PPLS sampling can be taken even in the presence of LNG-IUS in situ, because PPLA will not disturb the LNG-IUS inside the uterine cavity. Once there are 2 consecutive negative biopsies, then the long-term follow-up with annual endometrial biopsy is recommended in a patient of hyperplasia without atypia. Higher regression rate is achieved by increasing the duration of medical treatment from 3 to 6 months. This is what I was telling, that 6 months at least treatment is must. The studies which showed that treatment increased from 3 to 6 months, the regression rates were improved for LNG-IUS from 84 to 100%. For oral progesterone, it was from 50 to 64%. So studies and guidelines recommend that minimum period of progestin in a endometrial hyperplasia without atypia up to 6 months should be considered, minimum of 6 months. In a follow-up of high-risk women, wherein there is a high risk of relapse, persistence or progression, or a patients of high BMI, wherein patients, in this kind of patients, you need to do a biopsies at 6-month interval for the first 2 years at least, then long-term follow-up with the 2 negative reports, then the follow-up can be done on annual basis thereafter. If the patient is on LNG-IUS, we said recommended treatment is minimum of 6 months to 2 years. So after that, whether to remove or continue. In high risk of relapse, if there is suspicious, continue the LNG-IUS despite at 6 months if you find a regression of endometrial hyperplasia. So there is no harm in you continue the LNG-IUS. In the absence of adverse effects, if patient wants to remove the LNG-IUS after regression, the choice is up to her. But you have to counsel the patient that if adverse effects are tolerable and fertility is not desired, they should be encouraged to retain LNG-IUS for 5 years duration if it elevates AUB. Then how long to continue oral progesterone? That is the study wherein 3 months, in contrast to 3 months, 6 months at least progesterone is recommended. But in usual practice, what happens when a patient comes with continuous 3 months of medication, because of oral progesterone compliance issue, vomiting, bloating sensation, weight gain, etc., patient tend to have stop the treatment. So there is due to fear over potential adverse effects from administration of high dose and continuous progesterone and compliance issue, there is a chance of patient discontinuing treatment or the physician stopping the treatment at 3 months. But it is ideally recommended. The study showed that the regression rate is best up to 6 months if it is used minimum. But at the same time, you cannot tell the patient to go on taking a long-term progesterone, because in the absence of safety and efficacy data, routine use cannot be supported. And women experiencing AUB after the end of treatment should be advised to seek further referral due to slight chance of relapse. As I told you, progesterone causes very high rate of regression initially, but there is sometimes uncommon progression to endometrial carcinoma. That could be explained by the absence of or availability of progesterone receptors in the presence of long-term high-dose progesterone. So based on this, several randomized trials suggested that minimum use of progesterone at least should be 6 months, and hysterectomy should be advised if endometrial hyperplasia persists for 12 months despite the treatment, or if there is a risk of underlying cancer is high or regression is low. So what do we do? The most challenging situation comes when the patient having endometrial hyperplasia without atypia, but she wishes to preserve the fertility. then women should be carefully counseled about the risk involved in these conditions, because there can be a coexistence of progression to invasive disease, coexistence to ovarian malignancy, systemic involvement and metastasis, and the investigation results including tumor markers, radiological finding, histopathology should be discussed in detail involving gynecologist. So what happens if the failure of fertility sparing therapy fail to induce the regression of endometrial hyperplasia, atypical hyperplasia by 12 months, or there is an evidence of progressing to cancer? The option is hysterectomy. The risk of relapse is high in the first 2 years of diagnosis. We had one patient in the few months back. Patient came at 37 age, obese patient, infertility workup. Endometrial hyperplasia was diagnosed, and when the endometrial sampling was done, we found out that there was an atypical hyperplasia. Patient was given an option of oral progestin and LNG-IUS. She opted for oral progestin. 3-month continuous medication was taken, but at the end of 3 months, when we followed it up, it was atypical hyperplasia. Again, a patient was counseled and patient opted for hysterectomy. So this is what happens. Like in that patient, we would have considered maybe LNG-IUS would have been better than the oral progestin. But if there is a chances of persistence even after 3-month follow-up, then there is a chance of fast progression. So better to advise hysterectomy. If the relapse occurs during the follow-up, also hysterectomy is advised in these patients. So the counseling in the beginning part itself is very important. There are several studies which compare the oral progesterone and LNG-IUS, cyclical progesterone and continuous progesterone with LNG-IUS. But there was an evidence that LNG-IUS used for 3 to 6 months is probably more effective than non-intrauterine progesterone at reversing endometrial hyperplasia in the short term, up to 6 months, and long term they studied up to 2 years. But there was an insufficient evidence to reach conclusions regarding device-related adverse effects of cost or resource use. So there are several comparatively 2-arm and 3-arm trials also have been done. Progesterone oral versus LNG-IUS also has been tried. In that, regression hyperplasia was highest for LNG-IUS, that is 94.8%, compared to oral progesterone, it was only 84%. Rate of regression of LNG-IUS in comparison with oral progesterone, there was a study wherein they studied at 3 months, at 6 months, at 12 months, and at 24 months. Women treated with LNG-IUS compared with oral progestogens were less likely to need for hysterectomy during the follow-up. But there was no significant difference found between the frequency of irregular vaginal bleeding between the two groups. But definitely, there was a need of hysterectomy was less likely in the LNG-IUS comparative group. The oral and intrauterine progesterone for atypical endometrial hyperplasia was also studied. This was one study where there was an inconclusive evidence that difference in the regression rates were not very much comparable. But over the 6 months of treatment, main adverse effects were only nausea and vaginal bleeding, but there was no evidence of difference between the groups in the rates of nausea, vaginal bleeding in the but vaginal bleeding was more common in LNG-IUS group. So there are a lot of contradictory studies have come, but when regression is considered, LNG-IUS still tops the list. There is some word for HRT and management of endometrial hyperplasia. Also, when we are discussing with endometrial hyperplasia, definitely a discussion of tamoxifen also come into picture. Hormonal replacement therapy not routinely prescribed for women with uterus, and they should be counseled to report in cases of unscheduled bleeding. Those on sequential HRT preparation and having a endometrial hyperplasia should be counseled to switch over to continuous combined HRT or LNG-IUS. The most famous PEPI trial, that was postmenopausal estrogen progesterone interventions, wherein they studied that there were 45 patients who were on HRT were diagnosed with endometrial hyperplasia on sequential HRT. So they stopped HRT and these women were treated with oral progestogens so that the regression achieved up to 94% at the end of the study. So that is why the HRT patients should be either discontinuing their sequential treatment, going for a LNG IUS or continuous combined HRT preparation. This is another study which also supported that hyperplasia regressed to normal when the women were changed from the estrogen alone HRT to continuous combined HRT preparations, which has a progesterone in it. There was a study done before committing on the medical management, a patient of atypical endometrial hyperplasia. They studied this one to ensure the reproducibility of the diagnosis and determine the rate of concurrent endometrial carcinoma. There have been incidences where sometimes this atypical endometrial hyperplasia may be as a concurrent endometrial carcinoma on the biopsy diagnosis also. They have seen this also. There is a review of hormone treatment in a meta-analysis studied in 2014, wherein overall response rate to progesterone was 76%. They studied in the atypical hyperplasia group as well as grade 1 and stage 1 endometrial cancer also. So there was a mean time to regression was 12 weeks. Recurrence rate was 24% at the end of 1 year from diagnosis, but there was a 24% achieved pregnancy following progesterone treatment. There are several clinical trials wherein use of levonorgestrel, norethistone acetate, LNG IUD, metformin, medroxyprogesterone, and levonorgestrel and megestrol acetate has been studied. In one of the study, megestrol acetate, that is 80 to 160 milligram, there was a best pathological response rate was seen. Similarly, there was a better response rate for levonorgestrel and levonorgestrel IUD also. A patient of breast cancer usually come to a gynecological OPD as a follow-up, or they may come with abnormal uterine bleeding for a gynecological checkup. So tamoxifen used in breast cancer increases the risk of endometrial cancer from 2-fold to 3-fold. Women taking tamoxifen should be informed about increased risk of endometrial hyperplasia and cancer. Tamoxifen produces a sonographically unique picture of an irregularly echogenic endometrium attributed to cystic glandular dilatation, stromal edema, and hyperplasia of adjacent myometrium. In what is the association of tamoxifen and endometrial carcinoma? They usually present with either vaginal bleeding or discharge. So you need to tell the patient to come for follow-up. Patient taking aromatase inhibitors in place of tamoxifen are having a less chance of risk of developing endometrial hyperplasia or cancer. So assessment review of tamoxifen may be advised through a medical oncologist. Alternative aromatase inhibitors like anastrozole, exemestane, and letrozole may be considered in these patients who are risk for developing endometrial hyperplasia. The level of risk of endometrial cancer in women treated with tamoxifen is dose and time or duration dependent. So should women on tamoxifen be treated with prophylactic progestin therapy? Because we know that tamoxifen is causing a high risk of endometrial hyperplasia 3-fold. There is an evidence that LNG IUS prevents polyp formation and reduces the incidence of endometrial hyperplasia in women on tamoxifen. But word of caution here is that the effect of LNG IUS on breast carcinoma recurrence risk remains uncertain. So routine use cannot be recommended. So there was one study wherein Cochrane review found that LNG IUS reduced the incidence of new onset of endometrial polyp in women on tamoxifen for breast cancer over a period of 1 year. But there was no clear evidence that LNG IUS prevented endometrial hyperplasia or cancer in these women. So they updated a subgroup analysis therein which confirmed that endometrial hyperplasia is reduced as well as endometrial polyp formation. But still, the role of LNG IUS and on the breast cancer is still doubtful. So that is why routinely it is not recommended. How should a woman who develop endometrial hyperplasia while on tamoxifen should be managed? So there is an algorithm which shows evaluation of patient on tamoxifen. If they're asymptomatic users, then there is no need of evaluation. If they're symptomatic on tamoxifen, they require evaluation. If the endometrial hyperplasia turns to be an atypical endometrial hyperplasia, they can be in adjunct with medical oncologists. You can reassess the use of tamoxifen. If continues the uses of tamoxifen therapy, then it is, if it is required, then risks are accepted by the patient, then hysterectomy should be considered in women with atypical endometrial hyperplasia. There are few concerns while using progesterone. So all said and done, so many varieties of progesterone, LNG, IUS, magistral, acetate, everything is used. But then is medical management appropriate for all these women? The uncertainty arises here. That is because progesterone definitely gives rise to high spontaneous regression, but uncommon progression to more severe disease is one of the uncertainty. That is because long-term use of high dose of progesterone will deplete all the available progesterone receptors. The efficacy of this medicine or unresponsiveness is the reason for further progression. Obesity is one of the high risk, most of the patients associated with the endometrial hyperplasia. So is there any role for bariatric surgery? Some studies show that 10% of severely obese women could harbor asymptomatic endometrial hyperplasia. So there is a slight reduction of risk following bariatric surgery in these women. Few words about non-progesterone medications, that is GnRH analog in combination with LNG IUS, because GnRH alone can cause hypoestrogenic state, as well as the LNG releasing hormone device is recommended along with that. Among aromatase inhibitors, anastrozole, arimidex, which is a very important drug used to block endogenous estrogen production, which can be used breast cancer as well as in protection of endometrial hyperplasia also. Metformin found to have an anti-proliferative effect, and it reduces the insulin resistance and also induces progesterone expression in the endometrial cells. Hence, it enhances the efficiency of progestin therapy. So, metformin is now being studied in multiple cancer clinical trials as well as in combination with LNG IUS. So, LNG IUS metformin combination and medroxyprogesterone with metformin combination has also been tried. Which are the patients where surgical management is reserved? A patient of endometrial hyperplasia without atypia, definitely surgery is not a first line of therapy, because progestogens induces very good histological and symptomatic remission in majority of the women and avoids the morbidity of surgery. So without atypia, there is no surgery should not be a first line therapy. So which are the patients wherein surgery may be required? Indications for hysterectomy when women is not desiring to continue fertility preservation. They are the one wherein progression to atypical hyperplasia develops during the follow-up, or if there is no regression despite 2 months of progesterone therapy, or if there is a relapse of endometrial hyperplasia after completion of progestogen treatment, or there is a persistence of bleeding symptom, or woman declines to undergo endometrial surveillance or comply with the medical treatment. These are the patients who may require hysterectomy, who may be counseled for hysterectomy. So there was a concern about whether resection or endometrial ablation. So endometrial ablation not recommended for treatment of endometrial hyperplasia. Reason behind it, complete and persistent endometrial destruction cannot be ensured. Intrauterine adhesion may preclude future endometrial histological surveillance. While discussing about surgical management, supracervical hysterectomy should be avoided to ensure elimination of all other pre-malignant conditions, and laparoscopy may be reserved for stage 1, grade 1 endometrial cancers because of its advantages. Though there are several LAC trials have come, but stage 1 you can consider. What if the patient comes with initial management of atypical hyperplasia? Women with atypical hyperplasia should undergo total hysterectomy because of risk of underlying malignancy or progression to cancer. There is no benefit from intraoperative frozen section or routine lymphadenectomy. If patient is postmenopausal with an atypical hyperplasia, she should be offered with TAH BSO because of a concurrent chances of ovarian malignancy also. What is the role of progestin in advanced stage endometrial carcinoma? After the early intraepithelial neoplasia and early stage cancers, the next role of hormone therapy comes in the advanced stage of endometrial carcinoma or recurrent endometrial carcinoma. In the advanced stage 4 cancers, when the cancer has spread to other parts, as an adjuvant treatment, hormone therapy may be considered. In a high-grade cancers or those without detectable progesterone and estrogen receptors on the cancer cells are not likely to respond to hormone therapy. So high-grade cancers and in the absence of proper progesterone receptors, progesterone hormone therapy is of no use. What is the role of these hormones, progestrogens and other hormones in recurrent endometrial carcinoma? Endometrial cancer recurrence can be either confined to primary site of cancer, local spread, or it can be a distant spread to lungs or bones. For a local recurrences, again surgery is the first line or surgery followed by radiation therapy. But if women unable to undergo surgery, radiation therapy alone or in combination with hormone therapy may be considered. Hormones in the metastatic endometrial carcinoma, these are treated as stage 4 cancers. So either hormonal therapy or chemotherapy is recommended. Low-grade cancers containing progesterone receptors respond well to hormone therapy, but there is a poor response to high-grade lesions. High-grade lesions or type 2 lesions or UPSC or clear cell cancers, they don't respond in the absence of receptors. So coming to conclusion of my talk, the high-dose progesterone in combination with new epigenetic modulators promise better outcome in endometrial cancer. Minimum treatment of progesterone should be at least 6 months. LNG IUS is a preferred first-line management in endometrial hyperplasia without atypia. Hysterectomy is reserved for patients with endometrial hyperplasia persisting more than 12 months despite treatment. Risk of underlying cancer is high or regression is low. High-grade cancers and those without detectable progesterone and estrogen receptors on cancer cells are not likely to respond to hormone therapy. This is a summary. Again, I have put the different types of histopathology, risk factors, and the treatment, current therapies, progesterone therapy, surgical and other therapy, and the future targets. Thank you for patient hearing. Once again, I thank you, OmniCuris, for giving me this opportunity. I hope I have delivered to the practitioners and the gynecologists where to use, how to use, and what are the doses to be used, and how to evaluate endometrial hyperplasia. Thank you very much.